It's a great honor to be here, and the first thing I would like to do is to thank GIBLIB, Eric Desmarais, and Raoul Rosenthal for their kind invitation. My task here is difficult because there's not much evidence in the sensu strictus way. Vertical banding gastroplasty a long time ago was considered the safest procedure. That was, of course, before gastric banding appeared because it has a much lower morbidity and mortality than gastric bypass when done openly. But it is associated with a very high long-term complication rate, hence a high long-term reoperation rate, and has almost been totally abandoned and is not even mentioned in the statistics since more than 15 years now. Gastric banding more recently became the safest and is still probably the safest bariatric procedure when it comes to early morbidity or mortality. It is advertised to be reversible. I would more say removable. It entails no resection, preserves the internal rule, but it too is associated with a very high long-term complication and reoperation rate. If you look at the world statistics, it's pretty clear that the numbers have been declining since a number of years after gastric banding at the beginning of the 2000 years was almost the most commonly performed procedure worldwide, or certainly in some countries. But evidence-based medicine is based on high level of evidence based on randomized trials or meta-analysis of randomized controlled trials, and we certainly do not have any such study regarding RBMI. We have case series, a few comparative trials, mostly expert opinion. Furthermore, I would say indications for RBMI vary considerably between patients, between series, within series, and this all makes comparison between series and results very difficult. So this presentation does not contain a high level of evidence, but is mostly intended to summarize our current knowledge. I did a literature search using various terms and came up with a lot of papers, reviewed 180 papers for this talk, excluding papers focused mostly on technical issues or two mixed series. The general problems leading to RBMI after restrictive surgery are certainly insufficient weight loss or weight regain, default in surgical anatomy depending on the procedure performed, functional problems, excessive weight loss,